Hello and welcome to this special clinico-pathological case on Covid-19. My name is Ben Warne and I'm a Registrar in Infectious Diseases and General Medicine at Addenbrooke's Hospital and a Clinical Research Fellow at the Department of Medicine in the University of Cambridge. And I'll be the first in a series of speakers focusing on the topic of Covid-19. So apologies for the fact that this is being given as a virtual clinico-pathological case, but hopefully over the course of the next few videos we'll be able to update you on why we're doing these cases virtually, and to provide you with enough information to continue in your studies, safe in the knowledge you have a firm grounding in Covid-19 and what it means for your patients and from ourselves as healthcare professionals. The aims of this case are to provide a broad clinical overview of Covid-19, including multiple aspects of its presentation, diagnosis, pathology, management and prevention. We'll also be outlining some of the research that underpins our knowledge and understanding of Covid-19, including studies that were conducted in Cambridge. And bearing in mind that our time is limited here, and I'm sure that people will be very interested in this topic, we're going to provide links to further resources for you to continue to read in your own time as and when you need to. Now, please bear in mind that Covid-19 is still a disease in its infancy. So I first heard about Covid-19 on New Year's Eve at the end of last year, 2019, when reports were starting to come out of China of patients with an unknown cause of pneumonia from multiple hospitals. 6 months later, this is a headline from the end of June of this year, 2020, there have been over 10 million cases of Covid-19 confirmed worldwide, likely the tip of the iceberg. We are still finding out new information every day, and it's a very rapidly developing field. So apologies, but this will inevitably become out of date. Updates will be made to this CPC as the year progresses. Unfortunately, the future of Covid-19 and its impact on our professional lives and patients is still uncertain. So please be mindful of this uncertainty and continue to keep up to date as much as you can over the course of the next few years. Let's start with a few basic definitions. So Covid-19 refers to coronavirus disease. So this is the clinical syndrome that affects patients, as opposed to severe acute respiratory syndrome coronavirus 2, SARS-CoV-2, which is the virus that causes Covid-19. The main route of transmission of SARS-CoV-2 is direct person-to-person spread via respiratory droplets. That's what's thought to be the main contribution to transmission events. Other possible routes include contact with contaminated surfaces. So, for example, if I were to cough into my hand and then touch a door handle, and somebody else came along and touched the same door handle and then touched their face, then mucosal surfaces, that's a theoretical risk, but the exact contribution of that is currently unclear. There's also concern about airborne transmission, where very small water particles can spread further distances and can stay in the air for longer. In the community, the contribution of airborne transmission is really unclear, but in hospital, where we're doing things like intubating patients or ventilating patients and generating aerosols, the risk is potentially higher. And then other routes are really unclear. So although the virus is found in multiple body fluids, including in stool and in blood, how infective they are when they're in these bodily fluids is really unclear. Importantly, there's an unclear proportion of asymptomatic infections. So latest modelling data suggests that as many as 40% of people who are infected with SARS-CoV-2 may experience an entirely asymptomatic course of their disease. But for most people who experience clinical symptoms, the mean incubation period is 5 to 6 days, and it's thought that the maximum it can be realistically is probably 2 weeks. Critically important, though, is that of all the people that do experience any kind of clinical disease, the case fatality rate is around 1%, i.e. of all the people that get clinically significant Covid-19, around 1% of those patients will die. So for the rest of this talk, I'm going to talk through a case presentation, which in many ways is sort of our average Covid-19 patient. So this is a 77-year-old male patient who presents to our emergency department with a 2-day history of non-productive cough, shortness of breath and fatigue, and a 7-day history of increasing frequency of loose stools. Now, I'm going to spoil it for you now and tell you that this patient does indeed have COVID-19, but actually throughout the pandemic, people presenting in this way, only the minority of them will actually have COVID-19. And what's critically important is to consider what is the differential diagnosis, i.e. of patients presenting with these symptoms, what else might they have? When I think about the differential diagnosis of COVID-19, I start with other types of respiratory tract infection. So these include bacterial respiratory tract infections such as community-acquired pneumonia, aspiration pneumonia, or common viral respiratory tract infections like influenza and other seasonal respiratory viruses that can cause infection which is indistinguishable from COVID-19. And that can include things like human metapneumovirus, parainfluenza, respiratory syncytial virus, and so on. Our patient also presented with gastroenteritis-like symptoms, so diarrhea, and particularly in the elderly population, where diarrhea can be a more common presenting complaint for COVID-19, we have to think about other viral infections like norovirus, which can cause similar presentations, and other infections that can cause fever and cough, like tuberculosis, perhaps less commonly, but we need to consider in certain people with particular risk factors. And then also other infections that can cause a fever where the patient may have a cough for another reason. So things like cellulitis or other common skin infections where the presentation of fever and cough for another reason may be initially misdiagnosed as COVID-19. There are then a range of non-infective causes of cough, such as underlying respiratory diseases like asthma, chronic obstructive pulmonary disease, and pulmonary emboli, which can more frequently cause shortness of breath, and then other causes of cough, such as worsening heart failure. And it's not uncommon for combinations of these different conditions to exist in the same patients, which can make a diagnosis of COVID-19 quite challenging. Just to highlight this is our data from England and Wales looking at the number of respiratory virus infections across the last 10 years. And what you notice here is that every winter there is a spike in a range of respiratory viruses, including influenza A, here highlighted in red, and RSV highlighted in black. So when we're thinking about the differential diagnosis of COVID-19, it's important to consider what time of the year is the patient presenting, because a very different range of viruses that will be circulating in the middle of December, peak influenza season, in comparison to the middle of the summer, and there are comparably few respiratory viruses circulating. If we look at our epidemic curve for COVID-19 patients diagnosed at CUH, since our first case on the 10th of March, there was a clear increase in cases up until the end of March, when UK lockdown was introduced, that continued, peaked at the middle of April, and then started to fall again. Until more recently, we've had very, very few cases. If you're seeing a patient with COVID-like symptoms, just consider what the prevalence of COVID-19 is in your community. So if, for example, our patient were to present in the middle of February, when we had no recorded cases of COVID-19 in Cambridgeshire, it'd be very unlikely that the patient had COVID-19. The same is true if they were to present in the middle of July. Again, comparably very, very few cases of COVID-19 in the community. By comparison, if the patient were to present in the start of April, our peak season for COVID-19 in the first phase of the epidemic, the chance of them having COVID is much, much more likely. And that pre-test probability is key when considering whether a patient has or does not have COVID-19. Returning to our patient, he presents with 2 days of non-productive cough, shortness of breath, and fatigue with a 1-week history of increasing frequency of loose stools. Are these symptoms typical of COVID-19? This is data from a large cohort study of over 20,000 people presenting with COVID-19 across Europe during the first months of the pandemic. What it shows is that the 3 most common symptoms are fever, shortness of breath, and cough, all of which are very non-specific for COVID-19, as we've just discussed. But they also highlight that not everybody with COVID-19 has to have fever and cough. So up to 28% of people are afebrile at the time of presentation, which can be very difficult when you're trying to use symptoms like fever and cough to screen out patients who are non-COVID when they arrive at your hospital. There are also a range of other symptoms that patients have that are not classically associated with COVID. For example, over a quarter of patients present with confusion, which can make history taking difficult, and it can also mask other COVID-19 symptoms, which means that these patients may be inappropriately found not to have COVID when they first present at hospital. A range of other symptoms, including diarrhea, as our patient had, present in 20% of cases, chest pain, abdominal pain, sore throat. These are all symptoms that can present in a very large number of other medical conditions, which again makes triaging very, very difficult when the patient first arrives in the emergency department. Although more specific symptoms have been reported, so disorders of smell and taste, they're not universally present in all COVID-19 patients, and actually they're also not very specific. As anybody with hay fever will tell you, disorders of smell and taste are not that uncommon at this time of year. Once the patients move to a scenario 1 area with the appropriate PPE being worn, they're assessed by a clinician who takes a more detailed history. So this is a 77-year-old male patient of white ethnicity who presented to the emergency department via ambulance in early April, so at the peak of the first wave of the pandemic across the UK. And he presents with a 2-day history of non-productive cough, shortness of breath, and generalised fatigue. He has a 7-day history of increasing frequency of loose stools, up to 3 times a day, and his symptoms review is otherwise uninformative. He has a past medical history of essential hypertension, so high blood pressure, controlled on 3 antihypertensive drugs. Type 2 diabetes, which is well controlled on metformin, so tablet medication. Gout, well controlled on allopurinol, so preventative agent for gout. And he has some osteoarthritis of his hips and knees, pain which is well controlled on the opioid meptazonol. So a past medical history which is rather typical of somebody of his particular vintage. His social history, he lives with a lodger who's recently travelled to London and back. He's an ex-smoker, an approximate 20-pack year history, but gave up 20 years ago, and drinks no alcohol. He's retired. He's independent of all his activities of daily living, and is very, very physically active, plays tennis several times a week, but not at the moment under lockdown. He's had no sick contacts, he's been self-isolating, but still going to the shops, and this was at a time prior to the introduction of masks for visits to shops. So in reviewing this patient, you identify that he has a number of risk factors for severe COVID-19 and COVID-19 mortality. So this data comes from a large study where primary healthcare records were compared in several million patients across the UK with their COVID-19 status to see, of those patients with confirmed COVID-19, what were the risk factors for death. Now the graph here on the right hand side is a forest plot. So this is the most typical way of presenting data regarding risk or hazard ratios, where the bars and points to the left-hand side of the dashed line are protective factors for death, and dots and lines to the right-hand side of the dashed line represent increased risk of mortality. So here, for example, we can see that under age, that the older you are, the greater the likelihood of mortality. Similarly, male sex is a risk factor for mortality. Increasing levels of obesity and non-white ethnicity are all risk factors identified for increased risk of mortality. There is also the issue of social deprivation, so people who live in more deprived areas are also increased risk, and the mechanism by which some of these factors, including deprivation, social deprivation and ethnicity, the mechanism by which these occur is currently under study, and it's not entirely clear what the association is between these factors and increased risk of mortality with COVID-19. Large risk factor are comorbidities. So there are a range of underlying comorbidities which are associated with worse outcomes, including diabetes, as of this patient, immunosuppression, so underlying cancers, hematological malignancies and organ transplants, asthma, particularly more severe asthma, and other chronic underlying respiratory diseases, but also chronic cardiac disease, liver disease, stroke, dementia, and underlying kidney disease. So a wide range of comorbidities are associated with poor outcome in these patients. These risk factors for poor outcome are reflected in our local data here at Cambridge University Hospitals. So here you can see a breakdown of our coronavirus cases by age and sex, and you can immediately notice that the number of cases that we're seeing is higher in men and higher in people of an older age. If we break these cases down by those that died, you can see that the majority of our cases are in the older age group, and again that male gender is particularly important risk factor for death. The majority of those older patients also had a range of comorbidities. On physical examination of our patient, we notice that he is afebrile. He has a normal heart rate of 71 beats per minute, a normal blood pressure, has an elevated respiratory rate of 25 breaths per minute, and he's requiring 15 litres of oxygen, so the maximum we're able to provide for him in the ambulance to keep his oxygen saturations to a normal level at 97%. He has a normal cardiovascular examination, but has some abnormalities on respiratory exam. So he has bilateral basal crackles, and although he's able to talk in full sentences, which is quite common in patients with coronavirus, even with quite severe disease, he desaturates to dangerously low levels on any kind of physical exertion. He has a normal abdominal examination and a grossly normal neurological examination. Now, it's important to note that physical examination, along with patients' initial blood tests, can be entirely normal in coronavirus infection. But there are some clues that can be provided, particularly in more severe disease, that I'm going to try and illustrate for you here on this case. So here, all of the blood test results for the patient's initial blood tests are shown for biochemistry, with the normal values in parentheses after the result. So, for example, the urea is very mildly elevated at 8.5, but he's also slightly dehydrated in a patient who's had some diarrhea. And his other renal function tests are normal. Of his liver function tests, he has a slightly elevated ALT, showing some very mild transaminitis, which is also common in COVID, and a CRP, so a marker of inflammation in the blood, of over 120, so very elevated, and you can have a very wide range of CRP measurements in coronavirus infection. In terms of his full blood count, although he has a normal white cell count, the differential shows he has slightly low lymphocytes, which again is very typical of COVID-19, but is also present in a range of other pathologies, and a very mild anemia, so hemoglobin of 114. He also has a slightly elevated D-dimer, which again is very common in coronavirus infections. What's worrying about this patient is his blood gas. So although he has a normal blood pH and a normal blood PCO2 measurement, he has a very low level, very low partial pressure of oxygen, given the amount of oxygen that he's on. So he's on 15 litres of oxygen, so roughly 80% oxygen, which is struggling to maintain his levels of oxygenation, which again is common in very severe COVID infection. The patient's final routine investigation in the emergency department was this chest radiograph, which shows quite classic features of COVID-19, including bilateral opacities. Now, unfortunately, like all the other investigations and symptoms we've discussed, radiological findings can be entirely normal in COVID-19, particularly in early disease. And although there's increasing recognition of some specific changes, quite frequently in the emergency department, it's difficult to distinguish COVID-19 from other non-COVID conditions. We're increasingly recognizing that the spectrum of disease that we see with COVID-19 is actually due to different phases of the infection. And that in the different phases, you can have a range of different clinical symptoms and different clinical signs. The majority of patients experience a mild viral illness where the host is essentially responding as normal to the virus, causing mild influenza-like illness, a fever, dry cough, and associated blood tests that would be typical of any viral infection. normally very, very mild. And as I mentioned, the majority of people do not progress beyond this. They recover from the virus and have no long-lasting effects. In a proportion of patients, though, they have a more aggressive host inflammatory response. So this is where the virus perhaps migrates down from predominantly upper respiratory tract symptoms to predominantly lower respiratory tract symptoms, causing worsening shortness of breath, hypoxia, more prominent changes to their radiology and blood tests. Before finally moving on to a predominantly host inflammatory response, where the main pathology isn't due to the virus, but is due to the host response to it. And that's characterized by features such as acute respiratory distress syndrome, systemic inflammatory response syndrome and shock, and then very deranged inflammatory markers and other blood tests, which would be completely atypical in early mild viral infection. So in our case, the diagnosis of COVID-19 was thought to be very likely given the classical presentation at a time when we had a peak prevalence of COVID-19 in the community, and this was complicated by severe type 1 respiratory failure on 15 litres of oxygen. So he was tending towards the more severe end of the spectrum. The initial management plan at the time was for a discussion with intensive care, given the patient had very severe illness, requiring high levels of oxygen, and had good levels of pre-morbid function. Appropriate microbiological investigations were requested, including confirmation, SARS-CoV-2 swabs, but also microbiology samples for the main differential diagnoses. So other common bacterial infections in elderly patients being tested with blood culture, urine culture, sputum, and Legionella urinary antigen looking for atypical infection. And that was treated empirically with intravenous antibiotics while we were not clear if this was all due to COVID or due to a community-acquired pneumonia. And what's really important about this is to realise that at this present time, we are still working out what the optimum test is for SARS-CoV-2. So when this patient presented to hospital, he had 2 sets of swabs sent at the same time when he was first admitted. The first was a nose and throat swab, which came back negative, and a sputum sample, which was strongly positive for SARS-CoV-2. The reasons for this are still being clarified, but it's thought that early on in the disease process, the upper respiratory tract samples, the nose and throat swabs, are likely to be more sensitive than they are later in the disease when you have predominantly low respiratory tract symptoms and signs, and where sputum samples may be the best test to do. So these are the key learning points I hope you'll take away from this first part of this case. First, the presentation of COVID-19 is non-specific. And although the most common presenting features are fever, cough and shortness of breath, other symptoms are prevalent and also non-specific for COVID. The differential diagnosis is therefore broad and depends on your pre-test probability of COVID depending on the levels circulating in the community and other pathogens such as influenza that may also be circulating in the community. Basic diagnostic tests can provide clues to the diagnosis but can also be non-specific. And the key risk factors associated with poor outcome are age, male sex and comorbidities, but other important associations are beginning to come to light, including ethnicity and indices of social deprivation. There are other learning points I hope you'll have picked up on as the case has gone on that were picked up in later videos. Finally, if you'd like some more information on COVID-19, particularly the clinical aspects of the disease, here are 3 web links that may be of interest to you. The first is the Cambridge University Hospital staff portal, which contains a wide variety of our local guidelines, educational material, and our local data, including a summary of COVID and its management at CUH. Secondly, Public Health England have a wealth of information on local and national data and national guidance for clinicians on COVID-19, and the British Infection Association host a really excellent collation of web links. If you have a particular interest in any particular area of COVID-19, you're likely to find a link from that website, which would be of great interest to you. Many thanks for listening to this first part of the talk, and I hope you enjoy the rest of the CPC.